Okay, so good evening, everyone. Today we will continue with our presentation on the degenerative disc disease of the spine, the post-operative complications, and what should the radiologist know, and what the surgeons or the clinicians want to know from us. Yesterday we talked about the degenerative disc disease, the different types, and the nomenclature and the classification, and we had a lot of examples, and I hope it was beneficial. If there are any questions, we will take them at the end of the presentation. We'll have a discussion. So if you have any questions, please just keep them till the end of the presentation. So first of all, when there is a disc that is a cause or disc protrusion or herniation or extrusion or sequestration, like we said yesterday, and it was the cause of the patient's symptoms and the patient underwent surgery. Okay, so what after the surgery, post-operatively, what does the surgeon want to know from us? First, we should know, and we should tell the surgeon, and the surgeons should know also, that the specificity of the MRI in the first 6 months after surgery is very limited. It's not specific. So if we need to have a proper evaluation of the post-operative spine, we need to do the MRI more than or after 6 months from the surgery, not like within the first 6 months. Okay, and preferably we should know something about the post-operative notes. If there is any scar tissue, recurrent disc, arachnoiditis, epidural collection, spondylodiscitis, things like that are important to us. بس يعني unfortunately كنا نتشارك بهاي المعاناة انه السيرجنز rarely they write proper history for us. يعني اذا كتب previous surgery it will be a big achievement. So اسهل طريقة انه نسال المريض يعني ناخذ information as much as possible. انه is there surgery, at which level it was, duration for since how many months the surgery, and the recurrent symptoms started when. Okay, sometimes the patient can provide the answers to these questions and sometimes not, so we should do as much as we can to get as much information about the surgery from the patient or from the clinician or from the surgeon or whatever. We'll try to do our best. Okay. Regarding the post-operative lumbar spine, if the patient has a surgery in the lumbar spine and we are doing an MRI post-operatively, first we should know that the surgery has is successful in relieving the pain, long-term outcome in almost 90%. So 90% of the patients will improve after the surgery. But if it is a repeated surgery, a second surgery for the same location, for the same level, the success is less. About 60 to 80% of recurrent disc herniation will have a second surgery, and up to 38% of epidural scar tissue formation might undergo a second surgery. So surgery يعني الspine إذا أول مرة we expect the best results. The second surgery is unlikely to be as successful as the first surgery. Now, what are the types of the surgeries that are usually performed in the disc herniation in general, or kinds of disc herniation? Mainly there are four types: either spinal laminectomy, in which they remove the spine, the spinous process, and the lamina, both lamina, right and left. Or there is a less invasive or less aggressive surgery is the hemilaminectomy. They just remove one lamina, the right lamina or the left lamina, according to the disc, the site of the disc, and they go and try to curettage or suction of the disc is performed. Less invasive is laminar fenestration. They just make a hole in the lamina and do the curettage. And there are many minimally invasive surgeries that are specifically designed for pain relief. Medico-legally, we should specify at which level the surgery is done, because it might be done at an incorrect or improper level, or the new symptoms might be due to disc in another level, not the original surgical level. So, first of all, try to look as much as you can for any evidence of surgery. You need to look for evidence of surgery. For example, this is a level of lumbar disc, I think it's L34, and you can see here that the lamina is gone. There is no lamina here, and the spinous process is not present. So this is a spinal laminectomy, which is like the most extensive surgery they perform on a single level. Okay, the lamina, both of them are not seen, and the spinous process is not seen. So the posterior elements, almost all of it is gone, and you can see this is T1 pre-contrast and post-contrast images. So you can see at the T1, this is the thecal sac, and there is a lot of soft tissue signal intensity surrounding it. And after contrast, you can see it takes a diffuse homogeneous post-contrast enhancement, and this is due to scarring, post-operative scarring. This, if it is less, if this is less than 6 months, this can be expected. It's not pathological. Okay, after 6 months, that is a different question. Okay, I'll try to talk slow so that if there's any internet problems, might be corrected. This is the best I can do. So let's see here. In this case, also another example of spine surgery or disc surgery. You can see the fat here. There should be some fat. It's effaced in the epidural space, especially on the left compared with the right. There is some fat here on the left side. There is no fat. Okay. Also, there is generalized enhancement. Enhanced post-contrast. This is T1 post-contrast. There is generalized enhancement in this region, indicating expected post-operative scarring or fibrosis. Okay, can you please just mute the phone so that we can hear better? Everyone can hear. So there is this fibrosis that is showing homogeneous post-contrast enhancement, and this is expected post-operatively. However, the thing that is not normal or not accepted is these two dots of enhancement. You can see this tiny dot here and this tiny dot here. These are enhancing nerve roots. Enhancing nerve roots. Okay? Guys, if you can please just mute the phones, I will be grateful to that. Okay, so enhancing nerve roots here and this one and this one, and this indicate radiculitis. In this case, aseptic radiculitis, just inflammation of the nerve roots post-operatively, and this is aseptic. It's one of the complications of spine surgery. We will talk about it in the coming slides. So this appearance is within the first 6 months of the surgery. First 6 months, this homogeneous post-contrast enhancement is due to scarring or fibrosis, and it is expected. That's why we need to do the MRI more than 6 months. But the two dots here that are enhancing, they are inflamed nerve roots, and this is called radiculitis, aseptic radiculitis. Now, let's look here. What's going on? This is a T1 without contrast, and this is a T2 with contrast, post-contrast. You can see there is some homogeneous enhancement in the epidural space here, or the tissues around the thecal sac. They are showing some homogeneous enhancement, and this is expected fibrosis or scarring post-operatively, especially in the first 6 months. However, what is this? This enhancement within the disc. What is this? This is the surgical curettage tract. They put the curate and they try to remove some of the disc material, and this will result in granulation tissue within the disc. It extends into the disc, okay? It extends into the disc, okay? Just a second, there is someone waiting. I don't know how to admit parts. Okay, so So this is extension of the scar tissue into the curettage tract. Also, this is expected in the first 6 months. So if you see it, this is not an abscess, not an spondylodiscitis. It is just granulation tissue or scarring or fibrosis, whatever you like to call it, extending into the intervertebral disc at the site of the curettage. They are curated the disc, removed the disc material, and filled by granulation tissue. Now, هسه نجي على المشاكل والطلائب. What's called failed back surgery syndrome. Okay, these are the problems that we have with these patients. Of patient undergone surgery for a disc protrusion and he's not getting better. In fact, he's gone worse. This is what's called failed back surgery syndrome, or FBSS. It is characterized by intractable pain, functional incapacity following spinal surgery. لازم اكو previous surgery. اوكي، لانه هي اسمها failed surgery. لازم اكو surgery which not good, not successful in relieving the pain. Okay, so what are the causes of failed back surgery? The major identifiable causes, the causes that we can see and report, are the recurrent or residual disc herniation, arachnoiditis or radiculitis, spondylodiscitis, spinal or spinal neural foraminal stenosis, failure to correctly identify the source of the pain. يعني the level that we identified as the cause of the pain is the wrong level. Okay, something called dynamic MRI. Can you guys just mute the phone, please? Mute yourself because it's making some noise. Please just mute the phone or the laptop or whatever you are watching on. So failure to correctly identify the level or the source of the pain. Here we need something called dynamic MRI to show the spinal instability. We will talk about it later in some details. What is this dynamic MRI and how it's done? So, first of all, the most important thing is recurrent disc herniation. There was a disc herniation, the surgeon removed it, but unfortunately it recurred again, happened, another herniation at the same disc. So, we have to differentiate between recurrent or residual disc herniation, can be some part of the disc herniation still left, not removed surgically, or it can be completely removed and again recurrent disc herniation, and epidural fibrosis. We have to differentiate between these two. Is it a disc, recurrent, or residual, or is it a fibrosis? How to differentiate between these two? By taking into consideration the following points. If the obliteration of the epidural fat is by uniformly enhancing epidural space, this is fibrosis, like we've seen in the previous examples. إذا السبيس ده حوالين or around the fecal sac is enhancing uniformly complete, this is most likely fibrosis or scarring. While if there is central non-enhancement, this indicates recurrent disc or residual disc مثل ما شفنا البارحة بالسيكوستريشن. وهذا انه نلقي الانهانسمنت بس peripheral اكو central non enhancement هذا recurrent disc. If it is diffuse homogeneous, this is fibrosis or scarring. Please guys, please mute the phone, please, okay, because it's making a lot of noise. Okay, I'm trying to mute from my side, but it is not very easy, believe me. Okay, now let's continue. So, for example, in this case, this patient has a hemi-laminectomy. You can see this lamina here is intact on the right side. On the left side, it is defected. This here there is a defect. I will repeat the just a minute. Okay, there is a defect here. Okay, in the lamina. So there was a disc before surgery. There was a disc on the left side, and now the patient is complaining of pain. So there is failed back surgery syndrome or due to recurrent disc. How to differentiate? Is this a fibrosis or is this a recurrent disc? Give contrast. If the enhancement is diffuse and homogeneous, this is fibrosis. But if there is central non-enhancement, like this case, this is disc. Okay? Again, راح نشوف defect بالspinal canal. There is something here. Okay? This is the fecal sac, and there is something here compressing the fecal sac and narrowing the exit foramen. Okay? Could be fibrosis, خصوصا إذا less than 6 months, could be scarring or fibrosis, or could be recurrent disc. شلون نميز how to differentiate? We give contrast. شو راح يفرق لنا الكونتراست؟ إذا شفنا الانهانسمنت peripheral with central non-enhancement, this is disc. Recurrent disc يعني. If the enhancement is diffuse and homogeneous, like just a second. Like, for example, here, you can see the enhancement is diffuse and homogeneous. This is fibrosis, not disc. هذا diffuse وhomogeneous. بينما this one is recurrent disc. Okay? Now, let's see here. Again, this is T1 and post-contrast. Okay? Two different discs. So, first of all, let's see the first case. There is something here. Is it a scar or is it a disc, recurrent disc? We have to give contrast. And after contrast, you can see this is the film defect here. If we give contrast, you can see, first of all, there is an enhancement. There is an enhancement, but it is not homogeneous. There is something here. If we wait a little bit more, you can see there is another non-enhancing focus. So this is fibrosis or scarring with disc embedded in the fibrous tissue. There is a fibrous tissue with a disc protrusion in the fibrous tissue. Okay, so we are looking for foci of non-enhancement. Okay, so let's look here. This is evidence of surgery. You can see this lamina is defected here, and there is a filling defect here. There is something here. Okay, so is it a disc or is it a fibrosis? On the T2 image, you can see this filling defect, this space occupying lesion is causing a mass effect on the fecal sac. It's compressing the fecal sac. Okay, now if we give contrast, you can see it's enhancing. This is the fibrous tissue, the fibrous tissue, and centrally there is a non-enhancing focus. There is centrally here, a non-enhancing focus indicating this is residual disc or recurrent disc. We cannot differentiate if it is residual or if it is recurrent, but it is of no clinical significance whether it is residual disc or recurrent disc. Both of them have the same symptoms and the same management. So, let's see now another example. Previous surgery, and there is something here causing some mass effect on the fecal sac. Is it recurrent disc or is it fibrosis, scar tissue? Give contrast. The contrast is showing peripheral enhancement, central non-enhancement. This central non-enhancement is consistent with what? Central non-enhancement is consistent with residual disc within the fibrous tissue. This is fibrous tissue or granulation tissue or scar tissue, and central disc herniation. Now, regarding the scar formation or the fibrous tissue around the surgical level can be seen within 5 weeks. 5 weeks from the surgery, you expect to see mature scar tissue. يعني شوية أكثر من شهر, 5 weeks, we start to see some maturing scar tissue. Granulation tissue, it starts by granulation tissue, which is vascularized, and then it surrounds and penetrates into the substance of the disc herniation. This is normal. Granulation tissue at the level of surgery will extend into the disc, like we've seen in the few slides before. The granulation tissue will extend into the disc at the tract of the curettage. The part that's removed will be replaced by granulation tissue. This is a normal reaction. Scar tissue with mass effect. We see scar tissue that's causing some displacement, some effacement, some compression on the thecal sac, on the exit foramen. If it has a mass effect, it will cause minor deformity of the dural sac, some indentation on the dural sac, okay? Minor deformity of the dural sac, and does not necessarily mean that there is pathological scar formation. So within like 5 weeks to maybe 2-3 months, we will start seeing scar tissue. This is scar tissue. It can have minor mass effect, some deformity of the fecal sac, okay? And this not necessarily pathological scar formation, not necessarily it needs some management. We should look for it. The important thing is to look for the scar tissue after 6 months. This is the keyword, 6 months. بعد 6 أشهر ندور على السكار تيشو. إذا مسوي deformity of the dural sac بالarticles وبال يعني بالbooks in our books it says that deformity of the dural sac بالliterature, deformity of the dural sac more than 10%, just 10% loss of the cross-sectional area of the central spinal canal in the axial plane should be considered relatively abnormal after 6 months. يعني إذا جاءنا المريض مسوي سيرجري أكثر من 6 أشهر وطينا كونتراست وأخذ هوموجينوس بوست كونتراست انهانسمنت هذا البارت وشفنا مسوي ماس افكت على الفيكال ساك، إذا هذا السبيس هذا السبيس إذا 10% بس أخذ من مساحة السباينال كانال normal and shouldn't be considered pathological. Okay, so the mass effect either mild before 6 months can be considered expected، يعني هو مو normal بس انه متوقع. ما نعتقد انه هذا مسوي compression او pathological abnormality، بس اذا after 6 months لا this is abnormal. This is a cause of failed back surgery syndrome. هذا البيشنت جاي 6 months after surgery, okay, and there is surgery for the disc, and you can see there is something. This is T1 post contrast. We can see there is something here filling the epidural space. There is hypointense or isointense on T1, soft tissue intensity, let's say, in the fecal, in the epidural space, and it's causing some mass effect on the fecal sac. Now, is this a recurrent disc or it is a scar tissue? Easy. Give contrast. It shows diffuse homogeneous post-contrast enhancement. So this is a scar tissue. It is not a recurrent disc. However, this scar tissue causing mass effect on the fecal sac, and if you can see the nerve root here is also involved, effaced, compared with the right. The right is the normal one. The left is the abnormal one. Okay. The left one is effaced or compressed or invaded or whatever you like. More than 6 months, this is abnormal. This is a cause of failed back surgery syndrome. Okay, and they need to reopen the patient, redo the surgery. Another complication of surgical of disc surgery is sterile arachnoiditis. Sterile means non-biogenic, non-bacterial arachnoiditis. So it's just arachnoiditis, inflammation without germs, without microorganisms. Okay, so in 16% of up to 16% of post-surgical patients with chronically persistent lumbosacral spine and symptoms, they will have sterile arachnoiditis. يعني إلى حد 16% من البيشنتس اللي هم عندهم lumbosacral signs بعد السيرجري يكون الكوز sterile arachnoiditis. This is not something to be ignored. It is significant. شلون نعرف عند arachnoiditis البيشنت؟ There are 3 main patterns, 3 appearances راح نشوفهم. يا اما النيرف روتس اللي بالثيكال ساك يكونون clumped together، كل مجموعه هيك ملزقه واحده بالثانيه، اوكي، clumped nerve roots، او نشوف الثيكال ساك امتي ماكو نيرف روتس. ليش؟ لانه هاي النيرف روتس يعني تلزق adhesion للثيكال sac. They will adhere to the thecal sac, leaving the thecal sac looks empty. هي مو empty، هي موجوده النيرف روت بس صايره peripherally يعني stuck to the thecal sac. اوكي. الابيرنس الثالث هو العكس بالضبط، انه هاي النيرف روتس بمكان ما تلزق بالثيكال ساك تلزق ببعضها، من تلزق ببعضها تصير مثل الكورد كانه سباينال كورد، فيسموه سودو كورد ساين. اوكي. فوي سي intrathecal soft tissue or mass. Okay, this is a group of matted roots and they can even obstruct the CSF pathways, and this is called pseudo-cord sign. يعني يا اما تلطش او تلزق بالبريفري بالثيكال ساك، يا اما تلطش ببعضها كلها بالسنتر، او كل مجموعه تلزق سوا وتصير ماتد او clumped nerve roots. كلها signs of sterile arachnoiditis. طبعا sterile arachnoiditis ممكن فوكال تشوفهم بس بون ليفل يعني او مكان واحد وبعدين يرجع كل شيء طبيعي، وممكن تكون ديفيوز ماخذه كل النيرف روتس بالثيكال ساك يعني مال كودا ايكواين. نعطي كونتراست ايش راح يصير؟ Contrast enhancement of the thickened meningeal scarring and the underlying intrathecal roots may or may not be observed. يعني sterile arachnoiditis ممكن enhanced وممكن not enhanced. يعني إذا الكونتراست ما راح ينفعنا هواي هنا in this condition we make better use of axial T2 weighted images. It will be much more important to rule out sterile arachnoiditis. Let's see this at L4-5. Previous surgery, this is before surgery and this is after surgery. Okay, so you can see that this is the spine and this is the lamina right and left, and you can see here the lamina right and left and the spine are removed. So this is spinal laminectomy. Okay, so just think about it. If this is L4-5 disc, which level, which vertebral has this spinal laminectomy? On L4 or L5? We said yesterday the one that is away from the vertebra is the one that is above, and the way that close to the vertebra is the one that is below. So this is removed. Okay, now removed. So this is L4. Exactly. Very nice. Good answers. L4 spinal laminectomy. This is the L5. It's still present. L4 هو اللي missing. Okay. هاي خلصنا. زين. شوف البري اوب. This is the thecal sac and you can see nerve roots here. Nerve roots here and there. Okay. هاي بري اوب. جينا سوينا له post op. We did a post op MRI. Where are the nerve roots? They are missing. There is empty thecal sac indicating sterile arachnoiditis. تمام. عافية مروة. زين. نجي على السودو كورد ساين اللي هي عكس الستيرايل اراكنويدايتس. هاي الكونس ميدولاريس. Okay, and these are the coda equina. This normal appearance here. We see it like that, just some nerve roots. If we go down to the level of the surgery, you can see here, this is spinous process of L3. Okay, L4, L5 is missing. No spine, so this is spinal laminectomy at this level, L4 and L5. But what is this? It looks like a cord, another cord at the level of the surgery. It's not a cord, it is a pseudo-cord sign due to clumped nerve roots matted together. كلها ملطشة واحدة بالثانية صايرة مثل الكورد. تشوفها بالاكزيال تحس اكو كورد بنص الثيكال ساك. Which is not, it's not a cord, it is just a pseudo-cord sign of arachnoiditis. Again, this is L4-5 before surgery, and this is after this. This is the same patient at L4-5. Everything looks normal. The nerve roots are evenly distributed within the thecal sac. But at L3-4 level, at another level, there is a cord. We said that the spinal cord ends at L1, maybe L1-2 level. At L3-4, we should not see a spinal cord. So what's this? This is clumped nerve roots forming a pseudo-cord sign due to arachnoiditis. We see همين قلنا ممكن يكون focal, ممكن يكون diffuse. Okay? ممكن يكون focal, ممكن يكون diffuse. This is focal لأنه ال L4-5 is normal, ال L3-4 is present. So this is a focal pseudo-cord sign. نجي على الدايناميك ام ار اي. حكينا قبل شوي قلنا مرات نحتاج نسوي دايناميك ام ار اي بوست اوبراتيفلي حتى نشوف المشكله وين. but unfortunately حسب معلوماتي ما ادري اذا انا صح او غلط انه in our country in Iraq we don't have any dynamic MRI machine. It is MRI بس مو lying. The bed can move in any angle. You can see ممكن يكون البيشنت erect, ممكن يكون semi supine, ممكن يكون supine. اوكي يعني البيت يتحرك بداخل الام ار اي. الام ار اي مو بالعرض، خلينا نقول صار بالطول. اوكي مثل الاوبن ام ار اي بس مو بالعرض، بالطول. This is a dynamic MRI. It is used in يعني centers اللي هي يعني deals with disc problems a lot, spinal column or vertebral abnormalities a lot, but it is important in evaluating the spine in post-surgical cases, the dynamic MRI machine. So ايش راح يفرق لنا هذا؟ يعني اذا شنو الفرق عن الام ار اي العادي اللي هو اللاينج داون او السوباين ام ار اي؟ هسه راح نشوف اكزامبلز وراويكم الفرق الفظيع. طبعا ممكن يسوي دايناميك ام ار اي ايضا in a lateral bending position, in any position that you like, sitting position حسب البروبلم of the patient. زين خلينا نشوف هنا. This is a patient with low back pain after surgery. Okay, the lie down MRI. This is a normal MRI that we do in our centers. It shows nothing. This is the site of surgery. Okay, this is the site of surgery here, and there is no restenosis, no significant bulge or compression or anything like that. Nothing significant. So, does this mean the patient has no problem? No, it does not. We need a dynamic MRI. And what does the dynamic MRI show us? There is a significant spondylolisthesis, anterolisthesis, maybe grade 1 to grade 2. You can see it in the erect position. It is very obvious. And this is the cause of the patient's problem. And the surgery was in a not important or not significant level. يعني هاي السيرجري ما كان لها داعي بهالليفل. كان المفروض السيرجري تكون على ال 3-4 يسوون stabilization للvertebral bodies there. بس بدون dynamic MRI we cannot see this spondylolisthesis. ممكن بالسيرفايكال سباين نسوي نفس الشيء؟ طبعا ممكن. ايش راح يفرق لنا؟ خلينا نشوف. Now this is an MRI showing a disc at 2, 3, 4, 2, 3, 4, 5, 6. At C5-6 there is a disc protrusion or maybe extrusion. We need to see all the images, but anyway. So there is a disc herniation, let's say, at this level. But if we do dynamic flexion and extension, in the extension you see not only this one, there is another one here and there is another one maybe here. So there are يعني هذا الديسك هنا it's almost very small on the normal lie down MRI, while here it is very prominent. So the important يعني إذا سووا surgery بس على هذا بناء على هذا الام ار اي patient might not get benefit because there is another disc here. So they need to do the surgery on 2 levels. Okay, يعني it changes the management completely. Again, another example. Patient is recumbent or supine. You can see there is just some disc, small disc at L4, L5S1 level here, but doing in upright position, and the disc becomes larger, and there is some degree of retrolisthesis of the L5 over S1. You can appreciate the retrolisthesis. Okay. So this is the dynamic MRI. I hope some centers in our country might have it in the future. I wish that because it's very helpful to the patients. So after surgery, like any other surgery, spine surgery, patients might develop collections, epidural collections outside the fecal sac or the dior. What the clinicians want to know from us? They want us to give them the location of the collection. Most likely the collection will be suspected leakage. CSF is leaking from the fecal sac and is collecting in the epidural space. Okay, CSF collection. So they want us to report the location at which level, the extent from which space to which space, what from where to where, and because they might need to do drainage, proper drainage for like any other collection in the body. Is there any mass effect on the spinal canal? This collection is it causing mass effect? And if possible, it is important, but not always possible. But if we can tell him or tell the surgeon this collection, is it hematoma, seroma, CSF, or what or abscess, for example? What is it? What is this collection? If we can, it's very good. If we can't, well, we have our limitations also. For example, let's see here. This is site of surgery. Okay, there is the spine here is missing, and the part of the lamina on the right and on the left. And you can see this is T2 weighted image, and there is a big fluid T2 hyper intense indicating fluid collection extending from the level of surgery to the level of the skin incision. This is a big collection. We need to report its location, its size, and most importantly, is it causing compression on the fecal sac? Yes, it does. You can see here it's compressing the fecal sac. This might be symptomatic. Let's see here. What do we have? This is a spinous process, and here on the L4 and L5 level, there is no spinous process. You can see here, this is T1, this is T2. So, spinous processes are present here, they are not present here, indicating surgery at these levels, okay, at L4, 5 and L5 S1 level, okay. Then, what is this? It is something, space-occupying lesion, that is hyperintense on T1 and T2. And this was not present before the surgery. It is seen after the surgery. So it is a collection. يعني tumor ما راح يكون موجود ما موجود قبل السيرجري ويطلع بعد السيرجري. Okay? لازم إنه this is something post-operative. This is related to the surgery. So this is a collection. What kind of collection is hyperintense on T1 and T2? Either T1 hyperintense, T2 hyperintense is either fat or proteinaceous fluid. This is obviously not fat because it is not present before surgery. It is not a lipoma. Okay, so it is proteinaceous fluid, either abscess or hematoma. Okay, since the patient does not have signs and symptoms of abscess formation, this is most likely a hematoma. Okay, and you can see in the axial images the extent of the lesion. It is hyperintense on T1 and T2 weighted images. So this was a hematoma. Now, one of the problems of back surgery is the development of spondylodiscitis. Spondylodiscitis, it is an inflammation or bacterial pyogenic inflammation of the disc and the adjacent vertebrae. يعني إذا surgery على L4-5 disc لازم الديسك وال4 وال5 all of them are involved by bacteria, by involvement, by pyogenic infection. So it is a serious complication. Usually develops 1 week to 1 month. من أسبوع إلى شهر بعد السيرجري. Sometimes can cause long-lasting or permanent morbidity. يعني يسوي مشاكل يعني serious problem for the patient. منين تجي الانفكشن؟ Most likely it is intraoperative contamination. لأنه البيوجينيك organism isolated most of the times it's either Staphylococcus epidermidis or Staphylococcus aureus. Diagnosis يعتمد على clinical, lab and imaging findings. C-reactive protein CRP has proven more reliable screening test for infectious complication of lumbar disc surgery. يعني patient عنده lumbar disc surgery وcomplaining of persistent pain وفبرايل وكذا تسوي له C-reactive protein يطلع positive or high, then you highly suspect development of spondylodiscitis. تسوي له MRI not طبعا مثل any inflammation نحتاج نعطي contrast enhancement ممكن يكون normal بالvertebral disc and along the vertebral end plates post-operative. يعني post-operatively نشوف contrast enhancement بالديسك ونشوف بالاند بليتس مو شرط يكون due to spondylodiscitis, can be normal finding. لانه هو يصير irritation during manipulation بالسيرجري فيقوم ياخذ enhancement. اوكي، لكن اذا شفنا enhancing soft tissue mass surrounding the spinal level بالparavertebral soft tissue بالاpidural space يعني داير مداير الvertebral body. اوكي، soft tissue mass that is enhancing وواصله للاpidural space، هذا كل شيء يمشي مع السبونديلوديسكايتس. يعني post operatively نعطي contrast enhancement صار بس بالديسك او بالديسك والادجيسنت اند بليتس شيء بسيط enhancement، هذا ممكن يكون نورمال خصوصا بالريسنت سيرجريز. لكن اذا شفنا enhancement بالبارافيرتبرال سوفت تيشوز هذا اكثر يمشي مع سبونديلوديسكايتس. شلون نعرف ديفينيتيف دايجنوستس؟ بايوبسي، يفوتون ياخذون سي تي جايدد بايوبسي ممكن او بالسيرجيكال ثياتر ياخذون بايوبسي من الديسك and there will be يعني cultural sensitivity وراح يطلع عندنا diagnosis of bacterial contamination. I myself did some CT guided biopsies of the intervertebral disc space. It is not a very difficult procedure and it is highly beneficial in establishing the diagnosis of spondylodiscitis. Now, let's see here. This was a case of post-operative spondylodiscitis. First of all, this is T1 and this is T2 weighted image, and you can see the disc here is degenerated. It lost some volume, okay, compared to above and below discs. Here it is degenerated disc, and there is a surrounding signal that is in the adjacent end plates. على L4 وال L5. This is hypo-intense on T1 and hyper-intense on T2 weighted image. Hypo-intense, hyper-intense, okay. And طبعا هاي الإديمة ممكن واحد يقول هاي احتمال modic changes, modic type 1 changes. Okay, modic type 1 changes that becomes prominent, more prominent post-surgically? No, modic changes يعني should be present before or after surgery. هاي first. Second, إذا تلاحظ if you look carefully, this disc should be supposed to be degenerated لأنه مسوي له surgery وكان هو ال cause mass symptoms مال patient. Okay, degenerated disc should not have hydration بالnucleus pulposus. There is some fluid signal intensity within the disc. بينما هو المفروض يكون degenerated disc, dehydrated disc. لعدين اجى هذا الفلويد signal intensity والإديمة بالadjacent vertebral bodies. Possibility of spondylodiscitis is very likely. سوي له axial MRI, axial images, T1 before and after contrast. You can obviously see there is a soft tissue in the paravertebral region. Now, in منطقة paravertebral, and post contrast you can appreciate this soft tissue surrounding the vertebral body and also some of it is seen in the epidural space. This is very suggestive of spondylodiscitis. Okay? تتأكد 100% تاخذ biopsy. Please guys mute yourself. Mute the. Please, guys. There are some children shouting. Please, can you help me and mute yourself? Okay. Good. Okay, I muted it, I think. It's not getting muted, I don't know why. So, the other complication of spine surgery is sterile radiculitis. Sterile means non-bacterial, non-pyogenic. It is radiculitis due to manipulation. يعني يصير لأنه يضخون النيرف root, so it becomes inflamed, not bacterial. Okay? So, spinal nerve roots, شوف هاي يعني that's something we should know about. الspinal nerve root عندهم intact blood nerve barrier. شلون blood brain barrier؟ اكو blood nerve barrier بالspinal nerve roots. Okay? بس الdorsal root ganglia have no blood nerve barrier. بس الspinal nerves الجانجليا ما بيها blood nerve barrier. So هذا البلود nerve barrier ممكن after surgery 6 to 8 months يكون break يعني non-functioning non-working blood nerve barrier. يعني نشوف contrast enhancement بالspinal nerve roots 6 to 8 months after disc surgery is not pathological, it's expected. لانه هذا يعني يكون asymptomatic enhancement. Okay, if the patient has chronic failed back surgery syndrome, يعني failed back surgery صار لها اكثر من 6 to 8 months ونعطي contrast ونلاقي nerve root enhancement بالthecal sac, this is a clinical relevant finding. We have to report it in uncertain cases of postoperative radiculopathy. يعني البيشنت يسوي سيرجري بعد radiculopathy عنده بعد عنده بين اكثر من 6 to 8 months صار له نعطي contrast صار enhancement بالnerve roots. This is sterile radiculitis, okay, and can be the cause of the symptoms. For example, this is a case of surgical post-operative disc. It has the surgery was 1 year ago. 1 year ago, you can see the lamina here is missing. The lamina is missing, and the spinal process is missing. This is T1 pre-contrast, T1 post-contrast. Okay, T1 pre-contrast here and T1 post-contrast here. If you look carefully, you can see this dot here, this dot here taking contrast. This dot is a nerve root. Nerve root 1 year after the surgery showing post-contrast enhancement. يعني البلاد نيرف بارير مالته بعد broken المفروض ورا 6 إلى 8 أشهر 6 to 8 months it should be it should show no enhancement. 1 year is too much. This enhancement is abnormal. It is due to sterile radiculitis, which can be the cause of failed back surgery. Thank you very much. I hope you got benefit from it. If we have any questions or any discussion, I will be gladly answering them. And thank you for your attendance.